Hello, everybody. Better Spaces is a health and happiness solution for today's hybrid workplace. My name is Dr. Paul Kachoa with PAR5 Physical Therapy in Randolph, New Jersey, and I've partnered with them to bring you an easy and educational workday session. Today's session is shoulder impingement, relief, and prevention strategies. So this is a painful condition. It's caused by the compression of tendons in the shoulder joint. We'll talk a little bit about that. And we'll explore the mechanics of shoulder impingement, common risk factors, and exercises to improve shoulder flexibility, strength, and reduce your pain. Alrighty, so a little bit about me. I've got my doctorate back in 2010 from Mercy University in upstate Dobbs Ferry. Have a bachelor's in exercise physiology from Rutgers University. I'm a board certified orthopedic clinical specialist, a certified golf fitness instructor, golf medical professional, level 1 cross fitness coach, and a certified dry needling specialist. So let's get started and pull up my slides here. Here we go. That's it. All right, so shoulder impingement, relief, and prevention strategies. We're going to check the waiting room, make sure that we get everybody in that wants to come in. All right, so if you've been to any of my previous talks, one of the big things that you have to understand is that the information that we're going to go over today is very useful and aimed at a broad population. Okay, so if you're dealing with something specific, you know, an ache, an injury, a surgery that you're trying to recover from, make sure that you get a thorough physical exam from a medical professional so that you can have all the root causes and sources of your pain addressed. Because again, we're going to get into this later, shoulder is one of the most mobile joints of the body. It has the largest range of motion of all the joints, but we sacrifice that mobility with the lack of stability. So when we're moving the shoulder, it's really important that all the muscles that connect to it need to be functioning well so that you have full range of motion and no pain. All right, if you've been to any of my other classes, this video should be familiar to you. All right, try and summarize like 6-7 years of physical therapy, doctorate training into one slide. The body functions on this alternating pattern of stability and mobility. From an orthopedic standpoint, this alternating pattern of stability and mobility is super important for the way our body functions, because if we're missing something, if a joint or segment has reversed its role, it's not stable, it turns into a mobile segment, or a mobile segment turns into a stable segment, we've got pain or injury. So one of the things to keep in mind is that if we're looking at the shoulder joint, you know, it's designated as a mobile segment. All right. The shoulder blade, the scapula, is designated as a stable segment. And the next segment down from that is the thoracic spine, the T-spine. That's your mid-back, and that's designated as a mobile segment. Now, the alternating pattern here, mobile, stable, let's just say, for example, your thoracic spine becomes very tight. It doesn't move as much. If you're stiff in your T-spine, that segment becomes a stable segment. So it's reversed its role. So then your body has to figure out a way along this pattern here of how to fix that loss of motion. So what it does is just borrows range of motion and makes your shoulder blade, your scapula, unstable. It turns the shoulder blade into a mobile segment. And then we've got a gamut of issues that could happen. So if you're getting treatment or getting assessed for your shoulder or any part of your body, you got to make sure that that person, whoever it is looking up and down this chain. All right, because our body doesn't just function in single joints alone. It's a multi-joint system of systems that's all connected. So you have to make sure that everything is working well and it's fulfilling its role in this stable, mobile, alternating pattern. Okay, so let's dive in a little bit closer into what we're talking about here. The shoulder joint. This is the bony anatomy here. We've got the rib cage, the ribs, which actually connect to your thoracic spine, your T-spine in the back. The little red circles here. I'm going to pull this up so full screen so we could see. And maybe you can see my cursor. Yes, excellent. So this right here is your sternoclavicular joint. That is the only spot where your shoulder connects to the rest of your skeleton. If something goes wrong here, you can't even move your arm. Then out here on the other end of your collarbone, this is where your shoulder blade, your scapula, connects with your collarbone. This is called the acromioclavicular joint. And then this big circle right here on the right, this is how your shoulder blade interacts and slides and moves over the ribs. So that is another joint, the scapulothoracic joint. And then this one is the proper shoulder joint, glenohumeral joint. That's where the arm bone, the humerus, connects with your shoulder blade. All right, so all of those things we have to keep in mind. Let me pull up my camera back here. So making sure that we understand what we need to address and how things work increases your success in recovering or addressing an injury. So, because if you don't know how things work, you're not going to be able to fix it. All right. So a closer look at the shoulder blade and the humerus, the arm bone, upper arm, is it has all these bumps on it. There's a lot of bumps, a lot of ridges, and these are attachment points for muscles as they control the shoulder. An analogy that's been used a lot is a ball and socket joint. But the ball and socket joint that is the shoulder is almost like a ball that's on a T, very large ball, small T. So that's why we have a lot of motion in that joint. Now, you could probably see on this picture here on the left, there's a big hook, a acromion, that piece of bone from your shoulder blade is on top of the ball and socket. The space underneath that acromion is called the subacromial space. And underneath that subacromial space is a greater tuberosity in the humeral head. So here's a close-up of that, enlarge that again. So this space right here between these two bones is key, and that's typically where we see a lot of the impingement issues. So the socket, the ball, if the ball stays in the middle of the socket as you move your arm, great, you don't have any pain. If there's a little bit of loss of space in that, here it is, loss of space in that subacromial space, we've got some impingement going on, hence the title of our course today, our class. So let's look at how the muscles orientate. So you can see all these tendons that fill in, or all the muscles and tendons that fill in all those spots. And then that subacromial space has been replaced or filled in with the supraspinatus tendon. You can see that, one of the rotator cuff muscles. And there's an infraspinatus tendon that comes from the back of the shoulder blade and inserts in that same spot on top of the shoulder, the ball and socket there, inside the socket on top of the bone. All right. Next, if we look at the back, one of the biggest muscles that can influence how your shoulder blade is positioned and moves is your trapezius muscle. It's so big, comes from the base of your head, down the middle of your spine, and out to your shoulder blade. Make like a diamond, like a trapezoid. So they call it trapezius. It has an upper, middle, and lower segment. And oftentimes, if one segment is more active or has a higher tone, higher level of contraction or activity, it can inhibit or reduce the ability for the other parts to contract and work. For example, people who have tight upper traps, either they're stressed or they're postured or like this, the higher tone of your upper trapezius muscle, it inhibits the ability for your lower and middle to work. So if you picture the shoulder blade as it sits on the rib cage, as you raise your arm, that shoulder blade needs to rotate. All right, and there's a couple muscles that we're going to be talking about that create that rotation. If the upper trap contracts, all that does is just raise the shoulder blade straight up. That doesn't work well with the mechanics of moving your arm out in front and raising overhead. It helps more with abduction, which is out to the side and over your head. But the forward motion and reaching out here, I'm going to reach for a cup of coffee out of the cabinet and then take that mug out of the cabinet. That motion right there, if your upper trap is on and your lower trap and middle trap don't work, then the socket starts to face in different directions, and then we got like a little bit of impingement. The other muscle that's important is the serratus anterior. Now this picture here, that muscle comes from the inside point of your shoulder blade and runs forward and down and inserts into the ribs. All right, and what that does, that in addition to the lower trapezius of the trapezius muscle, It helps to rotate the shoulder blade up and takes your socket, instead of pointing down with that hook on top, it rotates it up, which gives you space to have full range of motion. All right. So, oh, here's a video here of a common impingement syndrome. So you have the orientation here of your shoulder blade, your arm bone, and the supraspinatus tendon that runs underneath that arch. And you can see that red hot spot. That's basically the pinchiness that we have. Now, that happens with genetic abnormalities or genetic predisposition to have more of a hook in your acromion or posture. And it also happens with age. Arthritis happens in joints. Joints degenerate over time. That space in between those two bones becomes smaller. That's why we see typically more impingement cases in people over the age of 50. So if you're over 60, 65, 70, there's a high case that you do have some type of tear going on in this tendon. All right, that is just anatomically, that's what the research shows. But whether or not it translates directly to having pain or loss of function is another story, because MRIs are very, very sensitive and they show a lot. But a lot of research and studies show that what you find and see on an MRI doesn't necessarily correspond to 100% to your function or pain. You could have a big tear and no pain, or a small tear and have a lot of pain, a lot of loss of range of motion. There's a lot of factors that play into what's your loss of range, loss of function, pain, and what your MRI does. So it's just because you have an MRI that says, hey, I got a partial tear in my rotator cuff, that doesn't mean anything to me. I need to look at your entire body as a whole, assess that, what's your range of motion like, what's your function, what's your strength like. All right, so we're gonna get into some fun stuff. Let's look at thoracic mobility. So the ability for your thoracic spine to move. It's a mobile segment. If that's not moving, then we've got problems. Scapular stability, control, and positioning. We talked a little bit about that. And rotator cuff strengthening. Rotator cuff muscles, they are the muscles that wrap around the ball and keep that ball in the middle of the socket so that when you have like a little bit of motion, it doesn't slide up. Okay? The analogy that I like to use is your car. If you have a front end alignment issue, maybe the front end's a little bit off, you can drive that thing. That's no problem. Go ahead and drive it. But over time, because you have a front end that doesn't face in the same direction, there's going to be more wear and tear on the tire. There's going to be more engine, more alignment stuff, or more suspension issues. So it's really important that we have good mobility and good control in the shoulder blade. All right, so let's get into it here. Let's pull up my two-shot. All right, so here we are. We talked about shoulder blade rotation as you raise your arm. So you think about the socket, typically at rest, it has like a little bit of a downward angle, depending upon your position of your shoulder blade on your spine. Most people are like this. That tips the shoulder blade forward and takes that socket and points it down. We want to be able to activate your lower and middle trapezius, pull the shoulder blade down and back. That opens up the socket, gives you more space for that ball to move. So a couple tests, super easy. If you're standing or sitting, you want to make sure that your back is straight. We don't want to have some hyperextension where your ribs start to separate from your pubic bone, your pelvis. You're going to bring your arm straight all the way overhead. What happens is that most people reach here and they start to say, hey, I could bend my elbow and then I've got more range of motion overhead. Look, I put my hand over my head. But that's not full shoulder range of motion because you bent your elbow. You want to have elbow straight, coming up, bicep to ear, without having all of this open up. Like, oh, look, I got full range of motion. You should be able to get to this position. Now, once we feel this thumb up, if that's pain-free, the next impingement sign test would be thumb down. We just do that same thing. If that hurts, that is an indication that there's some type of pinchiness or impingement. The other test that I give people is this test. You just put your fingertips lightly on your other shoulder and you bring your elbow to your face. You should be able to make this shape right into your face. Check the other side. That should be pain-free. If it's painful, that might indicate an impingement issue, subacromial impingement syndrome with your shoulder. That's just two of the tests that I do in the clinic. There's probably like 7 or 8 that I do that kind of fit in my diagnostic algorithm to arrive at a diagnosis. Okay, so those two things are pretty simple. You can do them on your own. Does it hurt? If it does, that you might need to have some type of further evaluation. You can go to a physical therapist. And hey, did you know that you can go to a physical therapist without a prescription? You don't need to go to an orthopedic surgeon and be like, hey, I got a shoulder pain. You just forgo that middleman, because they're going to give you pain meds. They're going to send you for an MRI maybe, or an x-ray. Just go to a physical therapist. All right, direct access in all 50 states. Just go straight, get it done, get it fixed, and then you're out the door feeling better. All right, so that's our range of motion test. Now let's look at how do we improve our thoracic motion. All right, so the ability for our thoracic spine to get out of this hunched over position is key to improve, let me show you, shoulder blade motion. Okay, so we're going to start. I've got a foam roller on the ground. This is one of my favorite ones. We're going to get down and use the foam roller on the back. All right, so we're going to have both knees bent. Let's get rid of this thing in my pocket here. Both knees bent, and then your hips are going to be on the ground. We want to position this foam roll starting on the lower ribs, not up top here, down here. Okay, so we're going to put it on the lower ribs, kind of situate ourselves here. My hips and my knees stay locked in place. My hands are going to go behind my head, or they can go across my chest. Whatever position you prefer, the shoulder blades need to separate. They need to be get out of the way. All right. Basically, we don't want to have the shoulder blades sit back and then do this. We want to wind those shoulder blades forward, get them out of the way, and then rock back. And I want to think about the intent of this motion. The intent is not just to kind of just go back and forth and be loose. I want you to feel that you can engage the abdominals. Everything on this side of the foam roll is locked up. It is not moving. Everything on this side of the foam roll is going to be mobile. So depending upon where you're going to put your hands, it doesn't matter. Hands go higher behind the head. That's a lot more weight going backwards, a little bit more aggressive. Or you put them across your chest and then go back. The key is to stabilize the ribs, keep the ribs down on this side so that this side can move back. And after maybe about 8 to 10 times, you can scoot yourself down to get to the next level. Now there's like 12 levels in your thoracic spine. You probably cover 3 of them each spot that you go if you move like 3 inches at a time. Sometimes you'll get a cavitation or a pop in the joint, which is okay, right? We're trying to mobilize or unlock our thoracic spine. So when we do this, we want to be slow and purposeful. Try to do like a seesaw here where this stays down and we take the other end backwards and we work through that. This is an excellent way to kind of get out of that seated office worker posture where you're hunched over your workstation looking at your laptop or your computer screen. So I'm going to repeat this until I get to maybe above the shoulder blade area or just at the shoulder blade, upper shoulder blade area, keeping in mind that my shoulder blade should be out of the way and as I go back. And I'm repeating this, and then if I find a spot that's a little bit stiff, I'm going to go back and repeat that, all right? So total time, somewhere between 2 to 3 minutes. It really depends on how stiff you are and how many times you want to move this to unlock the thoracic spine, okay? Because once we have the thoracic spine more mobile, the shoulder blade can roll forward, okay? The other thing I want to look at is what we call activating that serratus anterior. The serratus anterior comes from the bottom part of your shoulder blade, wraps around to the ribs. When that muscle activates, it pulls the bottom tip of your shoulder blade forward, which takes the shoulder blade and then rotates it up. So what I want to do is to work on what we call protraction, being able to move your shoulder blade forward and backward without bending the elbow. So this is protraction. As I'm moving my shoulder forward and backward, my shoulder blade doesn't move. It just kind of, it's the only thing that's moving. My elbow, my shoulder doesn't move. It's really shoulder blade moving forward and backward. And then here, as I'm moving forward, if you're looking in the mirror, we want to make sure that this movement doesn't turn into this. It's not coming up and I'm hiking the shoulder. It's really trying to keep that shoulder low. Once you can kind of get that down, we can add some resistance to this where I have my shoulder blade wrist and elbow stacked on one another. And I just relax, my chest goes down, and I could push away, shoulder blades separate coming forward. And it's important as we slide forward and backward that the shoulders stay away from the ears. My neck is long. I'm not doing this, where I'm rounded out like this. So oftentimes this movement becomes difficult for people who have chronic shoulder issues because their body has no idea how to activate that. So I tell people that, this video, this class is helpful information, but you need to have another set of eyes. Somebody to tell you, hey, are you doing that exercise correctly? Are you using the right muscle? Because the body will move through space and accomplish a task with the least amount of effort. It'll go through the easiest path. So if you have no idea where that muscle is or how it's supposed to feel when you contract it, your body's going to ignore it, try and finagle away to kind of compensate and use a different muscle. Use my trap, use my pec, use something, use my elbow. So that motor pattern drives into chronic shoulder issues because you have no idea how to move that shoulder blade correctly. So that's another plug. You have to go have your shoulder assessed. So that's the serratus anterior. The lower trap is another muscle that helps rotate that shoulder up by keeping the shoulder low. So if you're looking in the mirror and you're raising your arm straight up, you should not feel like we got to go like this and then your deltoid, the muscle on your shoulder, comes up by your ear and you hike up like this. We want to be able to keep that shoulder down as we come up, right? So one of the exercises that I do for that is just basically a Y movement, all right? It's putting your arm in this Y position, this diagonal, and lifting it back, all right? There's a couple different ways. I'm going to show you real quick. You can go back to this quadruped position and make the Y like this, trying to pull your shoulder blade away from your ear as you raise in that 45-degree angle, or you can come down into this position, makes it harder, all right, raising that Y, or on your stomach, and then making the Y like that, okay? The key thing, whatever position you choose to do that as you bring that arm back, that the shoulder blade stays down and it doesn't go this way. And I don't know if you've noticed, every time that I've raised my hands and did this, my hand was in a neutral position. Internal rotation of the shoulder sets the shoulder blade up to this position, and then external rotation sets it down. So we want to make sure that we can rotate externally or outward lateral rotation as we do this moves, and not internal rotation, which brings us to our next exercise, which is the rotator cuff. So as we want to try and strengthen the rotator cuff, let's grab bands. You can make this real easy. Just get some type of exercise band. You can get them anywhere. And one of the key movements that the rotator cuff does to set that shoulder blade in the socket, they're very small, is external rotation. External rotation, where you're going this way or this way, counteracts a lot of the bigger muscles. We've got more muscles that internally rotate the shoulder than externally rotated. So for throwing athletes, reaching overhead, the external rotators are very important. So if you anchor this end to something, all right, I'm just going to be close to the camera, you can see this. I'm just going to hold this with my hand. The key move is taking the shoulder blade down and back, and then rotating my hand out, okay? So it's here to here. The elbow, key point of performance here is that the elbow angle doesn't change. So I'm not trying to do this. I'm not trying to get this far by straightening my elbow. I want to make sure that my elbow stays locked and it's rotating and it's rotating. And you can notice I got space in between my ribs and my elbow. I never want to do this, lock this in and do it this way horizontal, because that's not the way that the shoulder rotator cuffs function. Sometimes I'll put something here, like a towel, rolled up towel, and we have that shoulder blade set in that right position with a little bit of space. And because there's space between my ribs and my elbow, my upper arm is or is abducted, or it's moved away. So the angle, if I keep my elbow locked at 90 degrees, the angle that rotates is from a down position to an up position because the axis of my arm is in that direction. If I tuck my arm in and do this, then the axis is this way. It's horizontal, okay? But shoulder blade angle here to here. This is one of the key ones that I give people to start with. If that's painful, then usually I just have people hold it, all right? An isometric hold, just holding that position, feeling like you can engage the shoulder blade while keeping the abdominals and the ribs down. We don't want to kind of pull the ribs up. We're just going to hold that position. And if you could hold that position for a minute at that angle, pain-free, then we could start to do the move. We could also do this at a 90-degree angle from the shoulder. So let me move back here so you can see shoulder blade and shoulder and elbow are at 90 degrees, and I come up and then down. Okay, so from the front, it's sort of like this. You can anchor this to a wall, railing, doesn't matter, but it's coming from this position to this position. Again, shoulder blade away from my ear, so I'm not up like this, and my shoulder and my elbow angle doesn't change. Again, start with isometrics if you feel you can do it, building up to a minute. Once you can hold a minute at whatever resistance you're using, then you could go for reps. Somewhere between 10 to 15 repetitions, 2 to 3 sets of that motion, whichever one you prefer. Alrighty, so let's take a look at my chat room here, chat box, and see if we have any questions. So super easy, super quick little mobility exercise drill to activate the shoulder blade and have things moving well and correct. Again, the shoulder blade is, the shoulder is one of the most mobile joints of the body. We need to be able to control that mobility with correct timing, coordination, and strength of the muscles that connect the shoulder to the rest of the body. All right, so some questions coming in. Can we get the video replay? Sure. The video replay will be available on the Better Spaces apps and many more past classes that I've done, they're on there too. Any comments about a crunching sound in the shoulder? Joints will make noise as they move. And does that mean that there's something wrong? Not necessarily. All right. As we age, these bony surfaces, they degrade, and that is natural. That is just the way the world works, the way that your body works. We live on Earth. Our bodies kind of break down. But does that mean that you have loss of function or pain? No. So if your joint, my elbows make noise all the time, if your joint makes noise, but it is pain-free and it does not lock up and unlock, then that's fine. That's okay, nothing to worry about, all right? Noise in a joint can come from several sources. Gas that gets popped in the joint like a little suction cup, or bony surfaces rubbing on one another, or tendons or ligaments kind of rolling over the bumps of a bone. Especially with the shoulder, in the previous slides I showed you, there's a lot of bumps around there, a lot of ridges around those bones. So certainly as you're moving a joint, such as the mobile shoulder joint, you might get a little bit of strumming of these ligaments and tendons moving over bones. So that might be contributing to the noise. All right, any other questions? I'm gonna give it the 5-second countdown. Make sure that we get all the information you need. I wanna make sure that this is helpful and informative as much as possible. You get the value out of the classes. All right, well, thank you everybody for joining me today. You can look for this session, like I said, and many more on demand on any of the Better Spaces apps. I will be back Tuesday, November 19th for elbow overload, preventing tennis elbow and golfer's elbow. Whatever elbow you want to talk about, we're going to talk about it next time. Usually elbow pains from overuse, such as when you play golf or tennis, and that can interfere with daily activities and sports. In this upcoming session, I'm going to cover the causes of these conditions, the symptoms, and how to prevent and treat them with targeted exercises and modifications of technique. All right, you're going to learn how to manage your existing elbow pain with proper ergonomics and rest and exercises to prevent it from coming back. All right, any questions, feel free to call or text me at this number here. My email is paul@par5pt.com or team@betterspaces.com. Okay, thank you for coming and be well.